Uh, Hi everyone, and greetings from Dharamshila Narayana Superspeciality Hospital, Delhi. Today we bring on the table two pioneers in the field of hemato-oncology and bone marrow transplantation, with proven metal at both national as well as international platforms. Both our professionals are invited round the world to talk on these subjects, and it gives me great pleasure to introduce Dr. Suparno Chakrabarti, head of the department, and Dr. Sarita Rani Jaiswal, lead consultant for our Haploidentical program at Dharamshila Narayana Superspeciality Hospital. To begin with, I would like to open this panel discussion with a very basic question. Dr. Sarita, can you please tell us, what is BMT and how exactly this BMT procedure works?
BMT. Most of the people believe that it's bone marrow transplantation, but to be precisely, it is called blood and marrow transplantation. And it is just a cellular procedure. And even it is difficult to conceive for most of the doctors who are not involved in this field, because most of them believe that it is a surgical procedure where it is not. So you all are aware about the kidney transplantation. So what is the kidney? It is a bean-shaped organ which lies on the both side of our body. Whenever transplantation is needed, patient and the donor, both of them has to take to the OT, and anesthesia is required. There is a proper surgical procedure. But bone marrow transplantation, there is nothing like that. Can you shape the blood and marrow? No, because it is just like a river which flows throughout our body, and it contains several cells like the RBC, red blood cells, white blood cells, and the platelets. And along with there are other cells as well. So where the mother cell lies? The mother cell lies in the bone marrow. And when these cells are defective, or in the other sense, whenever there is an excess of cells like cancers, or whenever there is a dearth or absence of these cells, we call it aplastic anemia. And at the same time, whenever these cells get defective, like thalassemia, sickle cell anemia, we need to replace these blood cells by giving the healthy donor stem cells. So in nutshell, it's a bone marrow transplantation is replacing the defective bone marrow with the healthy stem cell from the donor.
Okay, so sir, now we keep listening to these two confusing nomenclatures on a very day-to-day basis: bone marrow transplant, stem cell transplant. So can you please tell our viewers, are these two?
And also people say stem cell therapy.
Therapy.
I'll talk about all the three. Where Dr. Sarita left just now, that it is replacing the defective or unhealthy stem cells in a patient with a healthy stem cells from a donor. Now, that is the basic concept. But what is interesting is that previously, when this whole thing was started by Donald Thomas in the mid-60s, the first successful transplantation taking place in the late 60s, the whole concept was based on taking out bone marrow from the hip bones, which was generally done under general anesthesia for the donor, not for the patient. Now, it was very intuitive that bone marrow will be the place where you can get the stem cells which will give rise to blood cells. So when these cells were taken out and analyzed, it was found that 1% or less than 1% of the cells actually are the so-called blood stem cells which we are going to infuse. So the rest are all various types of cells. In case of bone marrow, it is bone marrow stromal cells which form the surroundings, a lot of neutrophils, a lot of lymphocytes, a lot of monocytes, and various other cells. So in effect, of everything that you're giving, less than 1% is what is going to seed the patient's marrow and actually cause the marrow to function from nothing. Now, to do that, you need to actually empty the patient's marrow. So that is called conditioning. So the conditioning initially was involving high dose of chemotherapy and radiotherapy. Subsequently, and I was fortunate to be a part of this in the late 90s, we developed what was called a non-myeloablative, means you don't need to destroy or kill all the marrow cells. All you need to do is give a little bit of chemotherapy to create a little bit of space in the patient's marrow and suppress the immune system. This was called non-myeloablative and later on reduced intensity conditioning. So this whole concept is conditioning. Now, in kidney or liver transplant, conditioning is not a big issue. You take the organ, give the organ, stitch the organ functions. But here, the organ is a very conceptual organ. Means you are giving a lot of cells and you are expecting, hoping that these cells are going to find the right place and work. So a lot of it is left to the way nature works. If you give some cells, which are stem cells, a small proportion of them, to an individual whose marrow is not working, these cells somehow find their way into the bone marrow. They can go anywhere, and they do go to a lot of places, but a small proportion, 2-3% of them will go and settle in the marrow, and they are the ones which will then grow, proliferate and differentiate and produce again a normal functioning marrow. This is an amazing thing of nature, and I always maintain that you cannot go against the law of nature to do anything which is sustainable, whether it's producing excess of carbon footprint, whether it's producing excess of heat, or cloning or genetic engineering to an extent which is not sustainable. So I would say that bone marrow transplantation, the term comes from how we did it before. I mean, say 20 years from the time bone marrow transplantation was developed, we knew that these stem cells which are inside the marrow can be pushed out by stimulating the marrow, loosening them from the marrow. So a large number of them would come to the periphery, and we can again harvest them. Means we just put a cannula on both hands, take it out of one hand, circulate it through a machine, take say 1 ml per minute, we collect out of 50 ml, we collect every minute and give the rest back. So this is called peripheral blood stem cell. Then the other source of stem cell is umbilical cord blood stem cell. Now this is again a natural source. When a mother or baby are tied through the umbilical cord, when the baby is born, a lot of stem cells are actually concentrated in that small portion of the umbilical cord. So you clump on both ends, collect whatever you can, and if the concentration of stem cells in marrow is say 1%, it is 0.5% in stimulated peripheral blood. In cord blood, it can be as high as 4-5%. But the problem with cord blood is it's a very tiny amount. Bone marrow, you can collect 300, 400, 500 ml from a donor. Peripheral blood, you can concentrate and collect up to 300, 400 ml. But in cord blood, you are limited to 30, 40, 50 ml.
Oh, okay.
So these are all sources of stem cells you can use for what we call hematopoietic reconstitution. But they all have their own roles, own set of rules as to how things would happen. So by and large, stem cell transplantation, bone marrow transplantation is extrapolation of the, but essentially it's a hematopoietic stem cell transplantation. But a lot of people, including myself, and I think you will also agree, that we like to call it hematopoietic cell transplantation, because we are 99% of the cells we are giving are not stem cells. So the best way to call it is hematopoietic cell transplantation. Now stem cell therapy is something completely different. it is a bit, wayward right now in our country. The concept is again similar. Blood is the only organ where you have plenty of stem cells producing it every moment of the day. There is no such organ in the human body. So we are not talking in stem cell therapy, we are not talking in regenerating or repairing the hematopoietic or the blood cells. I mean, we know that's a bone marrow transplantation or a hematopoietic stem cell transplantation or hematopoietic cell transplantation. But people have tried to use the same or similar stem cells to regenerate other organs. By and large, it is not successful in that way. But the bone marrow stroma contains a lot of cells, which we call mesenchymal cells, and they can cause regeneration of certain tissues like bone, cartilage. People have tried in regenerating the heart muscles. None of these trials are conclusive and they have not been proven beyond doubt. But if you say that I'll take hematopoietic stem cells and use to regenerate the brain or the spine or a bone somewhere, no, it's not going to work. There are different concepts. Clinical trials are going on trying to produce stem cells which can develop into other organs. So far, we are not there. But in India, this practice is rampant. Because hematopoietic cells are easily available, people are taking it out and infusing to gullible individuals who are desperate, especially with childhood paralysis or traumatic paralysis. So these are being done without any proven benefit.
Dr. Sarita, can you tell our viewers, why would someone need a BMT?
Yeah, because as you know, this blood contains several cells. So whenever these cells are defective in a better way, it means either they are too much proliferating, or there is no formation of cells, or there is some genetic defect in those cells. So what happens, to cure these things, we require to replace the stem cells like mother cells. Unless we are not going to, even if we are going to replace these cells, they are not getting cured. So we have to replace these mother stem cells, and that is how that mother cells will reproduce the new cells of hematopoietic origin, and that is how bone marrow.
So if you can name some diseases for the viewers, that's what I think.
Whenever there is excess of cells, like in the cancers, there are several cancers, acute leukemia. Now, if there is low dearth of cells, like deficiency or severe aplastic anemia, that we call this condition, which also require an urgent transplantation. And at the same time, whenever there is genetic deficiency or genetic mutation like thalassemia, sickle cell anemia, we need to replace these cells by replacing the mother stem cells.
So again, would like to know your views on how exactly a haploidentical BMT is different from other forms of bone marrow transplantation.
Yeah, so for that to understand, we have to go back while the concept of transplantation was developing. Initially, when lots of research was done by Professor Donald Thomas in the late 60s or 70s, it was initiated with the concept of fully HLA matched antigen. Like we all have the cells. Each cell has the signature, and which is identified by HLA typing, like A, B, C, TR, TQ. So we all are identified with this HLA, a pair of HLA typing, which should be initially, when it was started, should be 10 out of 10 matched. So, but if you think of the Mendelian law of inheritance, everyone will not get the matched sibling donor. Only 20% of patients were getting the matched sibling donor in the family. So that necessitates the generation of masked unrelated donor registry, and that is how these Western world like US, Europe, they have created their own registry. And if one is Caucasian, it is like the blessing for them because they can easily get masked donor from those registry. But
I think there is 70-80% chance if you are a white European descent, Caucasian, you get a match from those registries. But if you are
an Asian, the finding a matched donor from those registries is less than 10%.
Oh, okay.
And with each mismatch antigen, the chance of complication raises by more than 20%. So that
the
is
other
how
thing that maybe that there are registries which have come up in India also.
Yeah.
So what is the problem? Why are we not getting adequate match donors from those registries?
Because see, first, if you are looking for the international registry, what is we are looking at that the procurement of that donor itself costs the whole transplantation, like it is approximately 10 to 20 lakhs. And again, few of the Indian registries have been developed. They are developing in the phase of very early phase. They are developing, but we are not a philanthropic society. So even we found a donor from our Indian registry, he was not ready to donate.
Oh.
So that is the problem with the Indian registry. Although this is not a proper registry, but this is the thing.
I think the other problem with our country is that we are genetically very diverse, very diverse. Europeans or Caucasians are genetically much more homogeneous. Say, for example, HLA-A2 is a conserved gene amongst the Caucasians. A201, to be precise. Whereas we have A201, we have A35, we have A48, we have anything and everything that you can think of. Because you look at the history of our country, we have been invaded from everywhere. So they all have left their genetic imprints in the population. So there are very few maintained populations, like maybe some Marwari population, some Sindhi population, some Parsi population, who are more homogeneous as far as genetics is concerned. But by and large, it's not the case. So to say that I would be, matched with someone from Kerala, or for that matter Maharashtra or Punjab, is very unlikely. It's as unlikely as an European or Caucasian matching with me. So that is the major problem in developing. So to achieve that, we need a huge number of donors. And as Dr. Sarita said, that we don't follow traffic rules because we want to go ahead of the other person. So we don't care about others. So when it comes to donating a few of ourselves for others, we are less likely to do than, the Western society.
If I'm not mistaken, the team has already completed 100 haploidentical
I think we have not actually talked about haploidentical transplant
So
yet.
now coming to the full mismatch, then later gradually people thought of how can we extend the donor. So just a simple concept, when a mother conceives a child, she's carrying a 50% mismatch antigen as a child. So there is ideally she should reject it, but she's not rejecting that. She's tolerating, and she's carrying that child for the next 9 months in her womb. So this is the way the science of tolerance has come up. So mother is tolerant to the child, and similar way child is tolerant to the mother. So you have to remember, science has only succeeded when it follows the law of nature. And that's how the concept of half match or haploidentical transplantation has come up. Like we as a person, like if you have a patient of within the 30 to 40 years, what you can find that he is 50% matched with his parent, like because we all of us carrying a pair of gene from mother and another pair from father. Similarly, he is transmitting 50% of these HLA to his children. So he is half match with the father, parents half match with his children, and at the same time half match with the sibling as well. So this is what haploidentical transplantation is.
I think it's very important to mention over here that it has to be a haploidentical family donor. I mean, you can get an haploidentical unrelated donor, but the same science does not apply over there. So it is very, very important to conceive that this is based on a very solid natural law, which is far beyond the concept of a completely matched unrelated person. This is based on the biology of how two individuals have tolerated each other for 9 months and the offshoots of it. So a lot of people think that haploidentical transplantation is just taking a half-matched donor from the family and doing a transplant. No, it's not that simple. The selection of the donor is absolutely crucial in deciding the outcome.
Okay.
Yeah, it's very important. It should be half match from
So
the
it's
family.
mainly the selection of donor.
First
then.
degree
First
select
degree, okay.
family members should be there.
Okay. Now again, at the outset, I would like to congratulate the team. I think we have done almost more than 100 haploidentical transplant in the past 6 years. So now I think part of this question might have been answered as well, but still I would like to reiterate. What made you to start this haploidentical BMT program in India? When you thought about it 6 years ago?
I actually came back to India in 2010, and what I found, I mean, in the West, what we used to do is unrelated donor transplantation, as Dr. Sarita described. Matched unrelated donor registry, 80-90% of Caucasians get a 10 out of 10 match. So we don't have to bother too much about other sources of donor graft. Now, in India, the situation was vastly different. I mean, at that point, there was no unrelated donor registry. And if you have that lucky, you are amongst the lucky 10% to get a donor from an European or American registry, you have to pay 20 lakhs to get those cells, which is virtually impossible. I mean, it's the cost of the transplant, as she said. So we had to find a third way. Now, when I was abroad, I learnt about this procedure largely from the Italian masters, the pioneers of haploidentical transplantation, Professor Franco Aversa. They developed this transplantation in a particular way, and in India, when we looked at that option, it was very difficult to materialize it because of the cost involved. The cells had to be processed. The processing of the cell itself, again, is nearly the cost of procuring unrelated donor. So we had to find a more affordable way of doing it. And at the same time, the Johns Hopkins, in the late 2008, 2009, they had published their results on using something as simple as a regular medicine, 50 rupees per vial, cyclophosphamide, to enable this sort of transplantation. It is called post-transplant cyclophosphamide, or PTCY. Now, many people in their excitement would start doing it because it's apparently simple, but by the very nature of our training and thinking, we did not jump into it. We discussed this option with various experts across the world, including Professor O'Donnell at Seattle, who was leading this program over there at that time. We could not enter into their trial because we did not have total body radiation like we have in Dharamshila now. We did not have in that hospital. So we developed our own protocol, and we started doing haploidentical transplantation in very end-stage leukemia patients, very advanced. And the proof of principle was there because the first 10 patients we did, all 10 patients actually went through the transplant smoothly, because one of the major problems of haploidentical transplantation all the time before that was that the patients had severe reaction in the very early stage of transplant. So we had none of that. So whatever we did worked well as far as that was concerned. but they were very advanced leukemia, and within 6 months, 9 out of 10 patients relapsed. And India, especially in a private setup, talking of science is very difficult. The science was solid, but um, the long-term success in those cases was not there. The short-term success was there. And in science, you learn from your mistakes, right? So that is how you take science forward. And Dr. Sarita had joined me in 2012?
Yeah, early 2012.
2012, and we were sort of in both a situation of hope and despair, both. And at that point, we decided that we need to do a lot of research, a lot more research into it, as to how best to do it in these patients. Because we knew that in our country, patients who are in good condition, they don't come for a transplantation, and forget about haploidentical transplantation. So we knew that we are going to get patients who have advanced leukemia, very end-stage leukemia, so we had to do the best with that. And as we say that the necessity is the mother of innovation.
Innovations.
I can't call it invention, but definitely innovation. So we developed doing transplants in very advanced leukemia in a very different way than the rest of the world. Dr. Sarita was in Seattle in 2013-14, middle of 14 she came back, and she then pivoted the haploidentical transplant program at Dharamshila. So when I look back, I mean, those 5 years, the initial period of hope and despair for the 3 years, where we actually trudged on with hanging on to our science, trying to develop it. And then when we came to Dharamshila, we had our own lab, we had our own research facility, and we worked day and night to figure out what is the best way to take it forward. And that is how it all started, because out of, say, we have done what, 100?
More than 100.
No, we know, I mean, I think the exact number would be in the 120s or 30s, 130, around 130. If we take all the transplants from, out of which 100 are from this place. So we worked on several different protocols, and as I said, when I look back, I think it's an amazing journey. I will be so very happy to retire right now, because I'll be actually going out on a high. I mean, with the sort of results that I never imagined would happen. And people find it difficult that how sitting in India, and that also in a remote corner, no big institution to back you up, right? No government funding, no big body funding. How did this happen? Well, things happen for a reason, and so we are here today discussing it.
So, sir, you were mentioning about how it all started. It started with treating the end-stage leukemias. So currently, if I ask you precisely, what are all the diseases that are being treated currently with haploidentical BMT?
To put it very simply, any disease which requires an allogenic transplantation or transplantation from a donor can be treated with haploidentical transplantation. Now, the research in the field of malignant blood disorders, leukemia, lymphoma, myeloma, whatever works with any other form of donor works well with haploidentical transplantation as well, provided, here there is a catch, a caveat, that this is an expertise and experience-driven procedure. It's not like you can just come out of doing a DM in hematology or oncology and start doing haploidentical, which is actually happening across the country, which is scary. And because it is not a surgical procedure, people think it's about giving some drugs. But it's a lot more than that. It is a lot more than that, and the way I put it, I mean, this is something that bothers me. It bothers me a lot because Um, when someone actually comes out of his degree course, whether it's a DM or a fellowship or whatever, they are not equipped to become director of a transplant program. They need to be groomed, nurtured. So those who are starting their career, they are standalone or single-handed transplanters. No, it is a very experience-driven discipline. Even today, I would not know what is going to happen to my patient tomorrow, and if whatever happens to him tomorrow, is it something that I've already known or seen or done? The answer might be no. This is what I'm saying after 25 years of being in this discipline. So someone who's just passed out, you can't expect the same thing from him or her. So they need to be groomed. That grooming is lacking. And this is something that I think is very important, which is not happening in our country. So one of the important parts of regulating transplant is this grooming process. Like many other things, this is not there. But saying that, I think if the center has the right expertise in doing haploidentical transplantation, acute leukemia, lymphoma, which require an allogenic transplantation, they can have either donor. I mean, that is our take on it, which I think Dr. Sarita will expand a lot more on that.
Okay.
But just one thing, that we have to be very careful about other diseases. We cannot take every disease and say that we'll do a haploidentical transplantation on it. I'm talking about very serious indications like acute leukemia, lymphoma, and in some cases myeloma, but not every disease.
Okay, so we spoke about the numbers.
Yeah.
I think the next important aspect would be obviously the outcomes or the results aspect.
Yeah.
Should Dr. Sarita, if I ask you if your comment on compare on the comparison of our results with the rest of the India and the other parts of the world, so what would be your comment on this?
Okay, let me explain this transplantation. What is there? The concept of single graft, and that's all should be challenged. What we've believed after so many years of expertise, that not only is giving a single graft is sufficient to cure these diseases, they require little bit more adoptive immunotherapy apart from the giving the single graft. So we have developed our transplantation program that we give a special drug which causes the T cell blockade, and at the same time we give donor cells at a particular interval to get these special cells like the NK cell maturation, these mature NK cell to come early to take care of these leukemic cells.
What I would say over here is that it's important to say that while we are talking of it, that there are two important aspects. I mean, why allogenic transplantation is such a scary thing. Everyone should have it up front, but it doesn't happen because it's a curative procedure, but you still don't offer it to anyone and everyone because of the risk of complications. So the reason allogenic transplantation has not progressed where it could have gone is because we could not moderate the complications in the last 40 or 50 years to the extent we should have. I mean, it's markedly reduced. It's come down maybe from 40% to 10-15%, but even 10-15% is not negligible. And one of the biggest problems in allogenic transplantation, particularly haploidentical transplantation, is what we call graft versus host disease. So if you can talk a bit about it, that how we are separating out graft versus host disease from graft versus tumor or leukemia effect.
So one has to understand that this is the one of the dreaded complication with the haploidentical transplantation is the graft versus host disease. Why does it happen? Because we are giving this graft which is containing cells, and when these cells are generating a new immune system in the patient's body, sometimes they find the body as a foreign, and these immune cells start reacting against the patient's own body, and they hit these primarily three organs specifically, like the gut, liver, or the skin, and that led to the development of graft versus host disease. But what we found that the little bit of this GVHD, which should not involve the organ, is essential to get the disease cure, that is to prevent the relapse. So it is basically we have to keep a balance between the relapse or graft versus leukemia effect and the graft versus host disease. So basically then only we can give the excellent results.
And I mean, this is a fascinating thing that we have published all this now. That we have actually sort of, I cannot say that we have done it, but we are very close to it. That we have actually, in a very simple way, taken out the cells which cause graft versus host disease. We have not taken out by any manipulation, machine, expensive procedure.
Yeah.
It is a conceptual thing which we have developed, which has never happened in the world before. And this concept has come from a side effect of a drug. We are utilizing a sort of downside of a drug to enable us do this. And we are unleashing the cells which do not cause graft versus host disease, but cause graft versus leukemia effect. And you can tell us about the results with this sort of approach right now.
Yeah, so with this sort of adoptive immunotherapy, we have found that our results are extremely good. If you take especially for these high-risk leukemia, what we have found, the disease-free survival over 2 years is 75% in these high-risk, especially the high-risk cases.
I mean, to put it in perspective, I mean, in this group of patients across the world, the survival is predicted to be around 25 to 30%.
And our results
We are at
as good.
75
Yeah.
currently.
So I'm not saying that we'll always maintain that.
Yeah,
Maybe
but we have to wait for another several years so that we can proudly say that yes, this is the
Establish
way
the
to
results,
move ahead.
Okay. So this haploidentical BMT, would it be possible in conditions like sickle cell anemia and thalassemia?
You were interested.
Yeah, I mean, this is something that, that is the sore point about the whole thing. That look, I mean, you have a cancer, okay? You have a leukemia. The patient, whether it's a child or an adult, might not survive the leukemia for more than 6 months or 9 months without the transplant procedure, with just medicines. So you are justifying in taking a degree of risk, whether it's 10% or 15%, the risk of dying because of complications, in order to cure. Now, when it comes to thalassemia or sickle cell anemia, these patients can maintain themselves with supportive care. Means thalassemia, you keep on giving blood transfusion, iron chelation. Sickle cell anemia, you control the episodes of crisis, give hydroxyurea and transfusion as and when needed. Maybe you maintain a decent quality of life. Now, to subject them to this 10 to 15% risk is challenging. It requires a very clear understanding from the parents, from the physicians, from the society. Otherwise, especially in a country like ours, people explode that a patient of thalassemia has died, and then all hell will break loose. Now, that's why we recommend that any patient with thalassemia or sickle cell anemia should get a transplant within the purview of a clinical trial, so that we are doing things in a proper, organized, scientific manner. I'm not saying it should not be done, but it should be done within the framework of a clinical trial.
Right.
We have actually carried out 3 clinical trials in thalassemia and sickle cell anemia till now for haploidentical transplantation. No one in our country up to now has done any clinical trials in these diseases. we have taken the pain of going through this. The first two ways of doing it have not succeeded. One was associated with increased mortality, the second was associated with increased rejection. The third way that we have found now, which Dr. Sarita was referring to in how we block the T cells, the way we have developed that is touch wood, fingers crossed, working to an extent now in the initial cohort of 8 patients. So we are very cautious and careful in developing this in these disorders. We are not going to say that, okay, everyone should go and get a haploidentical transplantation. If there is a center offering the transplantation in the framework of a clinical trial, one should go. One can go for it, understanding the pros and cons. We are doing so, but I'm not going to recommend it as a routine procedure.
Okay, so I'm quite sure that there are quite a lot of centers who will be practicing this haploidentical BMT program. I think the viewers would be interested in knowing, how exactly our program is different from the rest of the other centers.
Yeah, most of the center take this haploidentical transplantation program at the last resort. They initially look for the matched related donor related donor, then from unrelated registry they want to procure the donor, but once those are not found, then only they go proceed for haploidentical transplantation. But what we are doing, we as a team have initiated, rather pioneered a protocol, and we are doing this kind of transplantation in most of the patients. Like our 90% of cohorts are haploidentical transplantations.
So we are not actively looking for a match.
Okay.
We are looking for the best donor, irrespective of HLA.
The worldwide data shows, see, as I told you earlier, there are lots in a family. For a patient, there are several haploidentical donors. Okay, so first and the most important is the selection of suitable donor who will justify the disease, particularly whether it is leukemia or non-malignant diseases. So like for the leukemia, we try to look into the several factors in the donor itself. Like this, suppose the monocyte, few monocytes are bad monocyte. If they are in the high number, they are going to react in the body. Few monocytes are good monocytes because they are going to develop tolerance in the patient. So this is the way, again, the type of donor is also important, and the most important, what we recently published, is the age of the donor. We are not looking for the matched sibling donor because of that only, because if a patient is there of the 50, 60, their siblings or matched related donor would be a higher age, and for them, if we choose their children, what we found, then results are extremely good. So that is how we are different from the other centers.
I mean, as I said, I'm very skeptical, I'm very cautious about saying these things, but there are two aspects of doing transplantation for malignant diseases. One, the patient should not die from transplantation. Second, the patient should not die from disease. And if you have achieved both, you have achieved a miracle.
Yeah.
Now, in a stepwise process, we are dealing with human beings, mind you, and to actually get there, it requires a lot of effort. Our transplant-related mortality has come down from nearly 30% when we started to less than 10% now. And this is, I'm talking about a large cohort of 70 odd patients in the last, 4 years. So 70 odd patients in 4 years, less than 10% transplant related mortality. That gives us the confidence to offer this procedure irrespective of whether you have a match or not, because we have sort of understood the science behind the donor selection. And there are several parameters we look at. When patient comes, a family comes and tells us we are 70% match, we are 80% match. We are not concerned about that. Haploidentical transplantation, mind you, it is no longer, I don't call it HLA mismatch transplantation as many call it. I call it a haploidentical transplantation. I promote that term because this haploidentical has a meaning. The one half has to be matched. Now, what is happening with the other half is open to our, judgment. We decide on that and various other things associated with it. As I told you, that these 99% of the cells, we focus more on those 99% of the cells in deciding who would be the donor.
Right donor. Okay. Last but not the least, I think we keep hearing about this new terminology, CAR T cell therapy, new form of immunotherapy probably. So, in your opinion, or in your expertise, what would you think that, with the introduction of this method, what would be the future of haploidentical BMT?
It's a very interesting question, and any answer is open to criticism. If you are in for big pharmas, you are in for the industry, you will say that CAR T cells are there to succeed. But because I have seen this discipline develop over the last 30 years, the ups and downs, we have 50 years follow-up on transplant patients. We have 5 months to a couple of years follow-up on CAR T cells. We know that even after autologous transplants, patients with myeloma, they develop a second malignancy at a much higher rate. After allogenic transplants, if they develop chronic graft versus host disease, they develop second malignancies at a higher rate. So I'm not talking of a cure over here. I'm talking of what is going to happen 10 years from now. Are we going to get more malignancies in these patients or not? That is something I'm open to see. Allogenic transplantation, whether it's a haploidentical, whether it's a fully matched donor, is a form of immunotherapy only. It is the first and the most vicious form of immunotherapy. I have never seen a patient who developed graft versus host disease, good going graft versus host disease, and survive, particularly if they go on to develop chronic graft versus host disease in an acute leukemia. I have not seen less than 1% of those patients have relapsed, which tells you something that this is the strongest form of immunotherapy. And the challenge is how you use this immunotherapy to get the maximum benefit with the least attrition. CAR T cell is exciting because you are, engineering, you are feeling like a surgeon. Okay? We have never felt like a surgeon. We have, we have left a lot to the Almighty, the nature, to do the right things. But here we are creating cells geared with, like small spears. And these spears are directed against the cancer cells. So they're going to go and hit the cancer cells. That's our expectation. That's what's happening in a lot of cases, most of the cases. But is it going to last the test of time?
We need to wait and watch then.
Yeah, this is an open space.
All right, I think that sums up. My sincere regards and thanks to both of you for joining us in this panel discussion. And last but not the least, we wish all our viewers very good health and best wishes. Thanks again for joining.